there been any developments?
Yes, so it's a good question and timely. So yesterday I presented the progress around integrated community teams at the NHS Sussex Public Board meeting. So Zoe and I were talking about how to effectively share that paper with our board now that it's in the public domain and what we do next with it. But I would say the integrated community teams delivery board has only been meeting for 10 months. So the first thing to say is that the progress that has been made was from pretty much a standing start. There was no previous work stream. This was, bringing people together, multiple stakeholders to work out what we were going to do. We had 3 key milestones for the first year. Milestone number 1 was to define the geographical boundaries of the integrated community teams. And as I reminded ICB colleagues yesterday, it's easy for us to now say there were 16. But that took probably a number of months of collaboration and negotiation about why that 16 was the right number. The rationale in the end that we went with was co-terminosity with district and borough councils in East Sussex and West Sussex, and co-terminosity with the City of Brighton and Hove's city councils, localities, which is a sort of quadrant in the city. So everybody in the end was happy with that, but it took some negotiation. The second milestone that was achieved was the development of community data profiles for each of the 16. So once they were named, the system partners came together, led mainly by the public health intelligence teams, to create profiles of what those 16 communities are. So there's a huge wealth of data that took months for the teams to get together, but that is a really, really rich repository now of information about the communities that we serve. And that was important because we've been trying to avoid pitfalls of the past whereby we look at NHS services and think what levers can we pull to reorganise, rather than what are the needs of the community that we serve and what are the natural assets that exist and how do we work in partnership with the voluntary sector and district and boroughs. So we've tried to stay true to that, and the community profiles have been a good enabler. And then the last piece of progress, the third milestone, which was due for the end of March, is the definition of the core offer. Now, that has been, there have been multiple viewpoints about that I would say at headline level, it's oscillated from the delivery board's view, which was let's keep it as a team of teams. So let's recognise that if we want housing, education, the voluntary sector, people in their own communities and health and care services to collaborate, it's not just going to be one team. So there's a sort of longer term vision around that, which I think is right. And at the same time, there's a sort of pace and delivery ask from ICB colleagues, which is, well, what's going to be different for the population of Ada or East Brighton in 12 months' time? So we're in this, we're trying to put a range of services and service areas together to be the definition of the core offer, but we still have this tension between how do we make a change for some of these communities quickly, i.e. in the next 12 months, acknowledging that this strategic ambition is a 5-year ambition. So to build to the community team of teams in these 16 areas will take longer. So at headline level, there are 3 progress areas. There's a delivery board next week, and one of the tasks next week is to set the definition of success for 12 months' time. So what does year 2 look like? But I do think now it's more coherent, and it was a very good paper written by colleagues that have been working on the programme with me. I think once we socialise that with the board, it's probably worth a longer conversation, perhaps in a kind of seminar discussion about what it means for us and what our thoughts are about how we respond, how we change organisationally because of it.
And how we include staff in that discussion. And just to confirm, it's the totality of the population, so it's including children's services as well.
Well, the starting point, I think in the fullness of time it will be, but to start somewhere, we're sort of erring towards a focus around frailty and older people, looking at best practice around the country, where, and I've spoken to chief execs in all parts of England about this, where they started with both children and older people in terms of vulnerable kind of parts of the population, they didn't get as far because the construct of who needs to be in the room is incredibly different. So in the fullness of time, yes, but we're erring towards starting with being able to identify older people through frailty pathways and build local neighbourhood solutions that keep people well independent at home by next winter. That's sort of where we're leaning to, but we will absolutely be including children. I think it's just a phasing and a timing thing. Thank you.
Excellent, that's really helpful. I think it's really good to hear that we're getting traction in something that's taken a while to come to fruition, and perhaps so we take an action that says let's circulate the paper and make sure we do get time for a conversation on this. Yeah. Okay. I'm conscious that our meeting today we've got lots of items to cover, so I'm going to pause us on the CA report in the interest of time and move across to another really important area, which is the corporate objectives for 24-25. Mike.
Thank you, Chair. So the board have seen a couple of iterations of these, but this is now a public board, so we can approve them if the board so wishes. So what we've set out is firstly an explanation of what corporate objectives are. The corporate objectives are our in-year targets really to drive forward our strategic goals, because the strategy is over a longer term. We need in-year programs that work to push those forward. What we've done this year is make sure that we're cognizant of all of our longer term pieces of work. There's a paper after this on the agenda around our improvement programs, which are our big strategic change programs that cut across big level amounts of services and lots of corporate departments also leaning in. So we're mindful of those, and we're mindful of our strategic goals because those are the ones we should be driving forward. And we've come up with a set of objectives that you can see on sort of page 26 of the pack. So I think we've only got about 5 minutes, so I won't, normally we do a round of all the execs, but I don't think we'll have time for that. Just to know what we have got is our first view of how we'll measure success on the last slide of the paper. So we've looked at that over a quarterly basis with some lead milestones and then moving towards how we measure outcomes. Because some of these projects will be defining what they're doing in the first quarter, we do need to define some of those outcomes in terms of the baseline and where we'll get to during that early in the first quarter, but during the first quarter as well. And we're cognizant of that, and we've not been able to say we'll move this metric by X% or whatever. But in the fullness of time, we'll have those kind of metrics.
Good. Thank you, Mike. Conscious we haven't got long, but Amanda, you had your hand up and then it went down again, and you're on mute.
Doesn't make a lot of odds because I haven't got much voice, but I think Mike answered the question. Actually, I was going to ask about because we called them success measures, and I kind of wanted to ask the question about the actual baseline and sort of target measures, and it sounded like that was all going to happen in the first quarter. So I just would find, I think the assurance of sort of saying we're going to do these things and we expect DNAs to go from a baseline of this to that. I just think that would be helpful but it sounds like that's part of the work plan for the first quarter, so that's fine.
So, Mike, I'm conscious last year we spent a lot of time talking about the words in the individual areas, and I have to say when I read this pack, I thought you've really encapsulated well the different areas of focus and recognising this is 1 year within our 3-year strategic intent. So, if I start with your interpretations around can we agree the corporate objectives, I'll open up to my colleagues, but I think the general sense was actually these really work. I'm seeing nods around the table, so I think we can say actually that's really helpful. The alignment to the strategic goals I think is useful because it just reminds us that actually it's not one for this and one for that. There's a lot of crossover in those pieces, and to pick up on Mandy's point, I think the question from our perspective would probably be around the success metrics, because at the moment what you're articulating is a lot of the activity that is being undertaken, and I think there's an opportunity to focus on, actually what does good look like at the end of the year, and I think that's probably a conversation for the exec to just articulate, recognising that it's important for us to understand where we start from. So are we clear where we are today, and what we aspire to do, and as we've talked previously. We put numbers in as success metrics recognising that they were aspirational in the direction of travel, as opposed to, targets. So I think that's what I would encourage the exec to be thinking about in terms of how you share with us what success looks like and what we track to over the coming year. So I think from the views around the table, we can approve the corporate objectives and we can ask the exec to just give consideration to how we further refine those success metrics. So I must say thank you, because that process was remarkably slicker and simpler and less painful than the process last time. Maybe it was for you as well. So clearly a lot of work has gone in behind the scenes to get to this point. You didn't just write it down last night. So thank you for that work with all the other things that were going. Good. Let us move on to the improvement update. Donna, that's with you.
Lovely, thank you, Mark. So this is the second report the board has had around our improvement programme, and what we've got is we've got an update around some of the key improvement activities that have been happening in the organisation, plus then a programme report against each of the 4 strategic improvement programmes that have all been led by the executive team. I'll go through the main areas from the point of view of the actions of the improvement leaders group. And then I think probably open it to questions around that, but then around questions around the individual exec leads for the improvement programmes, if that's okay. So one of the actions that we took from the board that we looked at just now was around how do we get an overview of all the improvement activity that's happening in the organisation. So you can see here we have a slide that demonstrates our initial attempt of having a single view of the improvement work. What we've tried to do is consolidate all the improvement work that the trust is doing around in the QI team, the digital team, in local services, and we've presented it like this, but we can cut the data basically in any which way we want to cut the data, really. What I think it shows, we've got a really good spread of work across our operational services and across localities. Large numbers as well. There's a lot of stuff happening, which I think is important to note, particularly a high level of support and leadership in the improvement area from the QI team and from the digital team, which is exactly what we would expect. And then also when we cut the data, what it does show is that our strategic programmes that are included in this paper have got the highest level of cross-working, which just reflects the sort of complexity of those strategic programmes and how resource intensive they are. So again, that's exactly what we would expect. So this needs a bit more finessing, but I think it's really helpful just as a snapshot, really, to see where we're at. Second point just to highlight is around the life stage framework self-assessment work. So this is the idea behind this, the purpose behind this was being able to evidence how we deliver our trust strategy at all levels of the organisation, particularly at a service and a team level. And I think we are able to do that now. What it has created is lots of interest. So the teams they receive their data within 24 hours of completing their self-assessment. They've got that data at their fingertips. It's creating lots of conversations, lots of thoughts, lots of ideas about where they need to improve. It's linking people together. So a PCN team here that's found this is linking with a PCM team in the other part of the county who's found something slightly different, and how can they work together on those. So people are really enthused and encouraged by this and are identifying their own areas for improvement, to the point where we've kind of had to say to the GMs, okay, we need you to think about maybe what your top 3 priorities are, because we can't do everything. So that piece of work is happening, and it's going through our sort of governance arrangements to have those conversations and agree what those 3 priorities are. You can see on the right-hand side of that slide just a few little examples about, again, how we can represent that data. And again, we can cut it in all sorts of different ways. There's going to be a project evaluation and an analysis report that comes from this project, and that will go through to EMG, so we can report a bit more detail through to the board as well in future reports. But really exciting stuff, actually. I'm really delighted to see this come to sort of fruition. And the last thing just to say was that we completed a self-assessment against the NHS impacts baseline requirements around improvement. And you can see on the next slide that SCFT have met all the criteria. You can see on the slide, this is all NHS provider organisations. So you can see, for instance, the vast majority, 96%, have an exec lead. Only 41% have staff training across the whole of their trust in place. So again, we're in a good place with some of those kind of fundamental elements of improvement. The next stage of the report is the improvement programme highlight reports. I'm happy to take questions on the first bit that I've just talked about, and if there are questions on the next bit, I'll probably ask the individual exec leads to respond to those.
Thank you, Dora. And it really is helpful to see the scale and the variety of change activity. And I think one of the challenges for us from a board perspective will be how much do we see and how much we just recognise that you're managing, because there is the tip of the iceberg piece, isn't it, around those strategic elements. Jill, let me bring you in first.
Yeah, I mean, I was the first thing when I saw this 212 project is wow, that is a lot of projects and really positive. I was thinking it from probably more from the operational frontline staff point of view, so I'm not sure if it'd be your Kate, but how much of sort of a general manager's time is on this part of work compared to doing the operational management, or is it blended?
Kate will have an answer. My expectation is that this would be a fundamental part of what they do, because improvement is how we do things. So I'm not sure that we would be able to kind of separate it out as to this many hours are spent on improvement. That would be my expectation. Whether people individually are looking at it like that yet, Kate, you might have a view.
Yeah, so I agree with Donna. Our sort of ambition is that this is a kind of blended part of a general manager's role, and transformation is just kind of part of what they do. I think we're probably not quite there yet, and I suspect if we looked at individual general managers, there'll be real inconsistency between some people focusing probably more heavily on transformation and less on the day-to-day kind of operational management, and some doing the opposite. So I think we've probably got some work to do just to kind of more clearly define what our expectations are around that. But yeah, certainly moving forwards, it's a key part of their role.
I mean, it's very positive at scale. When that's delivered and embedded, we will see a difference.
Yeah.
Yes.
Thank you, Matt. I just want to follow up on Jill's question, really. I mean, I think it's a great report, so thank you, Dom, because it really shows the depth and the breadth of what's going on in the organisation and captures that. But it's not only that the priorities for individual teams are coming out of this work, but we're reading the staff survey paper later on, and of course there are priorities for those teams as well. Is there an overview? I mean, it's probably from you, Kate, because it comes down to individual teams, just of what they're being asked to do and the priorities amongst those.
Yeah, I mean, at a sort of area level, there's quite a detailed overview of staff survey priorities, these priorities. There are groups that will be looking at that in its entirety, and particularly at kind of area FPQ meetings. They will be looking at all of that, and there are improvement meetings as well for each kind of area. So certainly at sort of area director, deputy area director level, they have got a good handle on the entirety of what we're being asked to do, and then we have to prioritise the priorities at times, as you know, in order to kind of get those achieved. But yeah, I think certainly oversight is there.
Because it's just balancing it from what we heard from Siobhan about the huge increase in demand to this work, which is clearly important.
Yeah.
But actually, we don't want to put staff under so much pressure that they're not able to cope with either side. Thank you.
Okay.
Thank you. I think also just adding to that, there's really good alignment to our proposed quality account priorities and our corporate objectives as well. So the focus that's coming out of here in terms of emerging themes around personalised care, patient communication and digital access, thinking about the virtual consultation piece aligns really well. Yeah. Thank you.
Don, I've got one question on the NHS impact based, and I think you explained it. I just wanted to make sure I understood this. So the table talks about 96, 95, 81, and then 41. So immediately, of course, I get to 41. And I think what you said was that's what 41% of all the trusts
so
have staff training.
Yes.
And
So are you
we
saying
are-
we have all of those elements?
Yes, so we are one of the 41.
Right, okay,
Sense,
okay,
yeah.
so it's not a case of we only scored 41% against the benchmark, we're scoring in all those areas, but only 41% of the trusts have achieved that. That was fun. And then the other thing, I thought this was really helpful. The other thing I was thoughtful of was, in your appendices, I really like the definitions, because it reminds us, what do we start with the aim of doing? And actually, my sense was there is more in those definitions than currently exists in some of the plans. And it's a 3-year programme. But actually, I think there's value in the teams perhaps just cross-checking against, we said we had aspirations in these 3, 4, 5 areas. Are they all articulated in the activities that we currently have underway? So I think that's just useful, because those statements, aims and improvements, I think are really helpful for us to just use as our guiding point to where we want to get.
I mean, it's a good challenge actually. Maybe it's what the exec leads need to do is go back and talk to their PMO support to make sure that they regularly review those programme definitions and make sure that the phased approach that we have for these programmes, because you say these are longer term programmes, that within that phasing we have included the breadth of what we've defined as being the problem statements, for instance.
I'm not sure if I have time, but I'll say quickly.
Sure,
It's a really good point, because I was just thinking about the urgent emergency care improvement programme and the corporate objective. And I was thinking, actually, if we're smart and we do that read across, the delivery of the 1-year corporate objective should be absolutely vested in this urgent and emergency care improvement programme. The error that we would make would be to be on slightly divergent paths, and we could easily do that if we don't do exactly what you said. So I agree entirely, and I think as an exec team, we just need to do that read across of the definition and the activity we're delivering and anything that's of relevance to corporate objectives as well.
So thank you, Donna. The final thing I was just going to observe, there's clearly been conversations at QIC, there's been conversations at Resources Committee, there's conversations at the board. I think we just need to make sure we don't duplicate or cause undue workload in terms of where are we seeking assurance and at what level. Because, it's nice for us to see everything, but actually we've got to be careful we don't get meddling in everything. And so I think there's probably a question, Michael, we touched on it in resources as well, around what is going where from an assurance perspective against this broader activity.
So just to clarify, my understanding is that this level of reporting comes through to the board at every public board meeting, which is every other month. There's no routine reporting through to the board subcommittees, but the board may ask the subcommittees to look at a particular element of this. But the exec management group get a fuller version of this, so sort of almost have that operational assurance against delivery.
Okay. Thank you, that's helpful. Let us move on. Caroline, we have the Workforce Equality, Diversity and Inclusion Action Plan, and my agenda says it's to approve, but the papers say to note. So is this something for approval, or is this for our awareness?
I'm looking at Zoe. She doesn't know I'm looking at her. She's keeping her head down. Well, should we talk through it and then we'll come back?
Yeah, I couldn't quite put that.
So, first of all, my thanks to Hazel Foss, who has written the paper, and also Sophie Leckie, who is our EDI lead, who's contributed to the paper as well. Hopefully the front cover sheet gives you a good indication of what this is, and the board will know, because we had a seminar discussion late last year about how complex the EDI agenda is and how many action plans and high impact actions and various other things we have to address, both locally as an organisation, but also at an ICB level, nationally, etc. So this is very much focusing on the high impact actions as described by NHS England. The actions are there based on their template, and this gives you a report on progress against those. Just a couple of points to note really on this. If having read the report a few times, I think my thoughts are that probably representation at a senior level, which is eights and above, so 8C and 9, and 8C, 8D and 9 in particular is something we need to address as an organisation to start addressing some of the disparity. And also the experience of internationally educated staff, and in particular their opportunities to progress in, and the board heard a staff story not long ago around that, and the issues around having your previous experience recognised, and I think that's another area that we need to look at. I think the last point is around health inequities for our workforce, and a paper was produced in the last couple of days by NHS providers around health inequalities, and it has a section on workforce. And actually, we have done quite a bit of that already, looking at the recommendations, including looking at increasing our work experience and work placements for communities that don't traditionally access employment. And again, the board heard a staff story about that, I think, a month or so ago. We also need to think about recruiting differently, and we've got a project to look at simplifying job description and person specification, so they're less heavy on NHS jargon and more open to people who traditionally, again, wouldn't have access NHS jobs. And then the last point is really understanding more around how promotion, how your background in any context will affect your opportunity for promotion, and so there's more analysis to be done. But I think there's a lot of actions being undertaken, and there's a list of all of the action plans that are relating to this particular thing. So this is just the tip of quite a large iceberg, but hopefully it gives you some assurance that there's a lot that we're doing on that. But happy to take any questions.
Thank you, Caroline. So I think, reading this through, and I recognise these are NHS mandated areas of focus and actions that we need to deliver. There is a lot of stuff, and we've seen that in a range of other different plans. I guess my question around assurance is, there are a lot of things in here that say by March 2024, and today is the last working day of March 2024. So, I mean, are you comfortable that we're in the place that we need to be across these actions, or are there areas where actually, you need to signal that we need to do a bit more here to get to the point that we aspire to be at?
Yeah, I mean, I think there are a few March 2024 areas, and in particular things like the having objectives, each member of the board having an objective that includes an EDI objective, and we've been working on that, haven't we, as a board, and we may not meet the absolute deadline because our PDRs are scheduled at the early part of 2025, just because of the cycle of what we do. I think some of them have got some of them are once a year kind of things. So, for example, the pay gap review has existed for a long time around gender pay gap, and we will do that in line with the normal routine of doing that. What we haven't done is the wider pay gap analysis around ethnicity pay gap, disability pay gap, and others, and that work needs to be undertaken. So I think it is reflected in the report that there are some things that are going to take longer. I think what will take the most time is the delivery of change, because we can do all the reports we want to do in March 2024, but so what we're going to do about it and what impact it's going to have is where the longer term things come in.
So can I suggest maybe that one of the people committees, you just bring back the assurance around the activities that I suppose are mandated for certain timelines, just so we can make sure we've sort of ticked them off, as it were.
Yeah, and just to make a final note on that is that a lot of this information is related to things like staff survey results, for example, which are annual reports, or the education and training assessments, the NETS assessment, which are also annual reports. So although there are lots of deadlines, actually they're based on information that is produced once a year at a certain time of the year. So, as usual, it's never quite as straightforward as it should be.
And you've answered one of my questions. So NEETs are now NETs, is that right?
So NEETs is different to NETs. So NEETs are people who are not in education, employment, or training. NETs is an assessment of education and training in workplaces.
Oh, okay. I wasn't sure what that was.
Yeah, it's another acronym. We like an acronym.
Yes.
I think your question has posed a thought in my head about the role the board has in oversight of this EDI action plan. It's such an important area of focus that we are getting more coordinated and coherent, I think, at exec level with. I think the People Committee does have the role that you've described, Mark, because NHS England deliberately wrote the National EDI Improvement Plan with specific dates that we have to do specific things, and I think that is the role for the People Committee. But I just wonder at what point we want to see this again. I'm not sure that annual seems sufficient, but also monthly is way too frequent. So, you know, do as a board we want to see progress in 6 months? Do we ask the People Committee to make a recommendation? I just think I don't want to lose the board visibility of this work first. Second, the organisation of this report and how the data is presented is a significant improvement on the version that we saw at the exec management group. So thank you to Caroline and the team for putting it into a visually much more appealing style. So I think this does look like a board level report, which was our ask. So thank you for the work on that. And I don't want to lose the work. So what frequency should we ask for it to be on the forward plan?
So I think, Caroline, and you alluded to it, Caroline, there are multiple different reports that have some sort of linkage to this broader area. So perhaps we could just ask you to take it away and say, look, we have some things where we have to formally approve external reports. There are other things that we can play through people. I think 6 monthly sort of feels right, but from my perspective, Mandy's nodding over there. But rather than say, tell us the schedule now, do you just take that away? Yes. And make sure that we have that enhanced visibility that I think you're right to flag.
Yeah, and I think specifically what we're doing, so your reflection of the things that we need to do, and if it's representation at 8C, 8D and 9, if that's what we're going for, let's tell the board in 6 months where we are with it. I'm not saying that is the one, but you know, the bringing it to life, assurance that we're delivering, I think will be a good.
And I think the other important thing for the board is, whilst we recognise all of the activity and the direction of travel, we don't want to get tripped up by things where you go, actually, we didn't do that, or we should have done. Or actually, we agreed we weren't going to because something else will lead into play that. So I think it's just that visibility.
Yeah.
Okay, good, thank you. So we'll note that.
So I think it's to formally ratify this as the action plan.
Okay, then we're happy to formally ratify this as the action plan. Thank you, I think it covers all of the elements. Thank you for that clarification. So, you've got a smile on your face, Caroline, so now's the time to move on to the staff survey results.
Yes.
Denise is sitting quietly in our audience. Denise is the Head of Learning and Organisational Development. Denise, you're very welcome. You wrote this paper, so it's nice you're here to hear the board discuss it. But Caroline, I'll pass to you.
Yes, thank you. So just before we start, I just want to note an error, a printing error on page 6 of the report. The heading should read 2023, but I'm sure all of you, as you read it, noticed it. So apologies for that. So thanks, Mark, for thanking Denise. I think we need to recognise the incredible work that's going on in that space that Denise has been leading for us for a long time now. And helped on the ground by Scott Hart, who's one of our HR business partners, who's delivering this in practice with teams, and both of them have been asked to present at regional and national events on our approach. So they are increasingly in demand to present our approach, which is a recognition of the great work they've been doing. So just a couple of things. The report is there, and I wasn't going to talk too long about the report. Obviously, you know that we've improved across all areas of the NHS People Promise, which Denise leads in her role. We've improved on recommend as a place to work, recommend as a place to receive treatment, and care is our organisation priority, and that's really important. Communication is focusing on celebrating those areas of improvement, but also supporting local teams to look at where they might want to both celebrate and improve, which is the way we've always done it, which is very much locally led. In terms of the bigger picture, because I know the board is often sort of wanting to know what else is going on in this context for the NHS as a whole. So nationally, morale and engagement has not recovered from before the pandemic. So the 2019 results nationally are higher than 2023 results. However, that's not the case for us. So we've not only recovered but improved on those two metrics. Staff engagement for us is at 7.3, nationally is at 6.9. Our response rate, as you know, was 72%, nationally it's 48%. So this again shows that we are, as Siobhan said, I think 18,200 and something, but you know, those figures kind of help represent that. A couple of more points from me. Denise is pointing in the report that this is an ongoing cycle of improvement. So we have improved from 21-22, 22-23. Denise calls it a 2-year cycle. So you do things and then you don't see them straight away, but you see them the following year. And I think that's again represented. The one thing that I think both of us agreed straight away as soon as we saw the result is that there is still far too much variation in the experience between staff groups and whether that's by protected characteristic or other elements. This is really a focus that we need to continue to have. And the final point is that I just wanted to note the issue around sexual violence. I will talk that a little bit more under the IPR section, but this is a very, very broad question that ranges from sexualized conversations, including sexualized jokes, to sexual assault. So this is a question, whilst it sounds like a straightforward question, it describes so many things that what we need to do now is do something to understand what it means for our people in relation to the answers they've given. And we are going to have a new role in our directorate that is going to focus on sexual violence, domestic abuse, and violence prevention and reduction. That role will help us do the deeper analysis and understand really why people have answered the way they've answered. So these are the key points I wanted to note, but happy to take any questions.
Thank you, Caroline. Leslie, I'll bring you in first.
Thank you very much, Mark. First of all, I just want to congratulate the exec team and Caroline particularly for this fantastic set of results. And as you say, it's the improvement time after year. So really well done, because it's great to have everything we're hearing in the news about how NHS workers are feeling so demoralised that actually this goes against it. I just want to pick up 2 points really, and one is about the bank-only workers survey. I'm sorry, I'm nitpicking really here, aren't I? But they're an important part of our workforce, and actually it's really important to hear their views. And the second point is about, and I've asked this before, Denise, so you'll know what I'm going to say next, is about volunteers equally, who have a really important role, and particularly going forward when we're going to be more cash strapped. These people are going to be really important in how we're developing and delivering services. And it's just how do we capture their views as a sort of subset to be able to put action plans in around those as well.
Yeah, so thank you. So the Bank Only Workers Survey, we started it before it became mandatory. So we've actually got more data than others. We haven't done the full analysis yet. We're waiting for the national results to be published to understand where we are. I mean, we can look at how we've done against last year, but this is such a new survey. We're waiting for April before we do further analysis. I mean, this would be something we would be more than happy to come back to People Committee on, if that would be helpful, because that we can put that on the agenda sooner rather than later. In relation to volunteers, they're not included in the annual staff survey, but they are included in the Pulse survey, which is the quarterly survey. I don't know the response rate for volunteers in the quarterly survey.
So we have sufficient responses from volunteers to get data, which I have shared with Mandy.
Okay.
So we could also do a short briefing to People Committee on the responses for volunteers, and maybe explore other ways of surveying volunteers, but they are part of the quarterly Pulse survey.
Brilliant, thank you.
Right.
Thank you. Yeah, I just wanted to echo congratulations on fantastic results, and really good as well to see so quickly coming to board, like your next steps. You know, what does that mean? What are you going to focus on next? And also just to lend my voice to this point around volunteers as part of the whole workforce. We discussed it at the last People Committee of, like, you know, across all the pieces, I would like to see more inclusion of volunteers' data alongside employee data.
It's really interesting because we put 10 minutes on this agenda. I was just sitting here thinking, I wonder how much time we would have spent had the results been in a different direction. And so we should recognise these are fantastic results. And looking at the comparisons elsewhere, looking at the fact that we're in the top decile in the country in relation to recommending us as a place to work is brilliant in the context of how the NHS is viewed externally and some of the stuff we've seen in the press today. So it's easy just to go, yeah, great, thanks. But actually, we should just take a moment to just reflect on this is a really positive set of insights from our staff. And we look, Caroline, to you and say thank you. But actually, this is driven by the leadership and engagement across the whole organisation. So we've got to thank all of the exec around the room and your teams, because actually the way people respond is generally driven by how their line manager operates and engages in their team rather than what Caroline's doing in her palatial office upstairs. There isn't a palatial office, I know that. So we say thank you. And I think the other thing to Leslie's point is, but not being complacent and recognising there are areas, when you talked about variation in staff groups, you solve that through the actions that you're taking through the other elements we've already discussed today and other things. And I think it's really important for us to recognise that. So, I think the board would say thank you to all of the exec for your leadership in this space and for your focus, because these things don't happen by accident. I'm absolutely clear about that. I'm going to turn to Siobhan and say, so what's the expectation for next year? Because you like to set that bar a little bit higher each time, don't you?
Well, I haven't really thought about it, but we did set ourselves a standard of 75% on response rate, and I think that's achievable for us. We were the highest in our sector on response rate. So we were the highest in the community sector for response rate. We were the highest in some sub-scores, but we didn't stand out as the best performing in our sector on any of the key people promise areas. And that, again, I think is achievable. We were very, very close in one or two of them. And that's not because we need to be seen externally as being the best, but it says in our class, in the category of NHS providers who are the highest performing in the staff survey, we can achieve best in class in the things that are important to us. Now, compassionate and inclusive is where we always stand out positively, and that is something we should be very proud of, because telling people that, I was really keen to get some messaging about how our recommend as a place to work landed nationally, and I just did some maths broadly, because that doesn't exist from the reports that I could see published around how many people were above us in each of the other sectors. And as you say, we were top decile, which is fantastic. So I'll work with Caroline, and Caroline will work with Denise about what our ambition should be, but we never stand still with it, whether it's a high response rate because that means more people engage and we hear from them and we can make change happen, or whether it's a best in class ambition. I'm not quite sure yet, but both those two things are on my mind, because I think we should strive for improvement and to be as good as we can be through the lens of the people that work here, because it matters to all of the exec team. The reason we have improved year on year is because we articulate the importance of caring for our people, hearing from our people, making positive change, being enabling. We don't always get it right, and the variability is something I know the teams are working on. But I think we did really well with response rate, and we were close. We were close to achieving our target with a couple of technicalities in the last few weeks. So I think let's set something realistic and ambitious. And if we don't achieve that, but we achieve brilliance somewhere else, that's fine too. But improvement, I know, is something that we can demonstrate year on year that we're good at. So not the absolute. I haven't had the conversation with Caroline yet, but PDRs are coming up.
I'm looking forward to it.
Yeah, I know you always do. But I think actually within that there's a serious piece to the board, which is the ambition piece, because we recognise this is not about look how great we are. It's about this is a really good set of results. How can we push on?
Yeah.
And that for me is a really important message. So thank you for that.
And so finally, this is a massive recruitment and retention opportunity as well, because people know it's such a public thing. If more next year, people, if it's more than 74%, or if it's the same, 3/4 of our workforce say this is a great place to work, it's one of the best advertising tools we can put into our marketing. So, it matters because we want great people to come here and to have great careers. So yeah, you're absolutely right.
So thank you, Caroline. Thank you, Denise. Thank you, more broadly. Right, we will move on to item 10, which is the annual Green Plan progress report. Mike.
Thank you, Mark.
You can stay if you want for the rest of it.
I have some.
We look forward to reading them in due course. Thank you.
Thank you.
Mike.
Thank you. Thanks to the Care Without Carbon team for pulling the report together. The report, it doesn't feel timely because this is a report on last financial year now. One of the reasons for that delay is we always have our carbon emissions independently verified. So it's not just us kind of estimating things and then putting a great number down and saying it to you. We can say that with some confidence that this represents sort of real carbon reductions. To remind people why this is important, sustainability is a key strategic goal of ours, and environmental sustainability, climate change has an impact on the health of our population. While we deliver care, which is obviously our main purpose, that emits carbon emissions and has other environmental impacts. So there's a loop you can get into by not being conscious of our environmental impact, in that we could make the situation worse and therefore impact the health of our patients. So it's really important to us that we are a key player. We're also a large institution, and if we can lead on something such as sustainability, we can demonstrate a way forward as well. So being a leader in this space is important to us for the health of our population, which is obviously our core mission. So there are three aims, and the way we try and balance everything, because we can't just aim at reducing our environmental impact without being aware of our strategy. So we've got the three aims of reducing environmental impact, but balanced with improving health and well-being of our patients, staff and communities. So we can't reduce environmental impact if it's detrimental to the care of our patients. We need to balance those things. And the third thing is about investing in the future. So that's about financial sustainability and sustainable decision making. So again, we can't just reduce environmental impact in the context and make our financial situation worse. We have to kind of balance these two things out, and that's why it's so tricky to achieve. The good news is we've got a net zero target, net zero carbon emission target for 2040, which is our headline emission, and we were on track in 22-23. So we can show that we're still on that flight path. It gets tougher and tougher as it goes along though, so easier in the earlier years. As we get more and more to 2040, we are going to be reliant on what goes on in the wider economy and the wider environment. So we just need to be aware that we can make a lot of impact, but we're reliant on the economy and and other things happening nationally that will also help us reduce our carbon emissions. But without effort, we won't get there ourselves. It's a tough goal. There's some great work going on, and we've talked about the great work, and in this report we've kind of led with actually where projects that actually their main aim is around improving care for patients have that environmental impact. And we've done a lot of work over the last year and been looking at tools that help people assess the environmental impact of the project and ensuring we've got a part of the forward here. Jenny Bent is contributing, and so we're ensuring there's sort of clinical interest and clinical leadership around environmental change as well. So the report sets out some of those examples and sets out how these aren't just environmental projects on their own, they're broad, multifaceted projects that drive environmental improvement. One of the last things as well, because I've talked a lot there about sort of carbon reduction, but climate adaptation, so how our services and buildings are going to be able to adapt to the impacts of climate change is something we've also been thinking about and doing a lot of work on. But there is still more work to do in that area, but it's a very important part of our green delivery plan, because some of the impacts of climate change are inevitable. We've been seeing some of them over the last few years. So knowing how we're fit for purpose, fit for the future, and we can still deliver high quality services with those expected changes, be it higher temperatures, be it flooding events, then putting these plans forward and understanding how we do adapt is going to be really essential for us over the coming years. So I was going to pause there really for questions. That's kind of set out a key, some of the key headlines, but happy to take questions from the board.
Thank you, Mike. Conscious this is a sort of backward look because we need time to get the data and have it verified. And I know through committees we're looking already at the current year and looking forward. So it's a very helpful and comprehensive report covering a whole variety of areas. Let me open up to board questions. I've got a couple of things I just wanted to just explore.
Thank you, Mike. It's a very detailed report. I mean, trying to distill from it what our priorities are to reach our target, but because you've already said it's as we go on, the target becomes more difficult to achieve. So just thinking ahead for the next couple of years, what areas are we really focusing on to actually try and achieve those targets?
Yeah, so we've shown in there a sort of pie chart showing where the emissions come from, and at the moment we're talking about our direct emissions. There's then indirect, which we do want to switch to as well. But in our direct emissions, looking at our buildings, our estate, making sure it's as efficient as possible, making sure we're heating, lighting, etc., done in the most efficient way. So moving to electric and things like air source heat pumps, like we've done in Chavey. So that will have a big impact. Our journeys, which then links very much, you can't just say we're going to change journeys without looking at our sort of care delivery models, but making sure our journeys are as efficient as possible, be that through electrification of fleet, be that through making sure we're not having sort of wasted journeys, and that will both help staff time and therefore release time for care as well as help with the sustainability. So those two issues, and then actually when we move into indirect, our supply chains, massive impact there. There's good work going on between the Care Without Carbon team and procurement in terms of understanding how we can procure in a way that kind of drives sustainability. There's lots more general engagement across the staff.
But these are going to be
those are big ticket items.
These are particularly the estates one is very dependent on capital available, and the quality of our estate is in pretty bad in some places, as we know. We've discussed it around this table quite frequently.
Yeah.
So so you think the work that you're planning within this will actually achieve that next target at 2025?
When you, so 2025, we're tracking as we go. It's tough, but we seem to have a route through. But when you go into the final pages, there's a sort of some key action plans on 47, 48 of the pack. And you'll notice there is a lot of amber there. So I can't give you full assurance that we've got all the answers to kind of drive this forward at the moment. There's business cases being developed and work undergoing to move things forward. There's a red here as well. So our leased estate, even bigger footprint than our owned estate. And obviously we only have influence over landlords rather than direct control. So we are working with NHS Property Services as our biggest landlord. They do have green plans as well, but actually we're not seeing the pace in the evidence yet. So there are risks.
So with our leased estate, if they do achieve carbon reduction, would that count towards our target?
Yes, where we occupy, yeah.
Thank you.
Dipesh, let me bring you in. I can see you have your hand up.
Yeah, thanks, Mike. I was interested to know, do we understand the impact in terms of finances, maybe in efficiencies, but also costs, like, in terms of not just now, but like how we budget for the future sort of evolution of this plan?
So we haven't got the full extent of the financial resources required. Not all plans are being developed, but we're working up business cases. We do know we're not going to be able to achieve everything on a long list of plans, which is why we're going to need to target the biggest impact schemes. But for instance, each year we're setting aside some of our capital plan for sustainability initiatives, but it is a balancing act and priorities kind of compete. So if there is, Leslie referenced the quality of some of our buildings. If there's a urgent backlog maintenance issue, we're balancing and prioritising availability of capital against urgent backlog maintenance work. The kind of golden ticket is when you're upgrading or changing something, even if it's urgent backlog maintenance, and you do it in the most sustainable way. Or if you're moving into a new properties and new buildings that you kind of upgrade and make sure they're the most sustainable. So we haven't got all of the answers to all of the financing that would be required to get all the way to the 2040 net zero target at the moment.
I think it's a really interesting challenge for us generally, Mike, which is we are facing into increasing, as you well know, financial challenges. And we saw with Chailey and we see elsewhere that the most sustainable way isn't always the cheapest way, particularly in the short term. And frankly, we operate on an annual budget cycle in the NHS. So I think there is a real challenge for us as a board that says, how much are we willing to invest to do the right thing for the future, given the constraints that we will face today and tomorrow, and the demands not only in sustainability, but in broader service delivery, patient care, and other opportunities. And I think that's going to be a really tough balancing act for us as we go through the next couple of years, because for me, the trajectory isn't probably as comfortable as I would like it to be as we look into the future years. Susie's joined us in the room to hear this, but I don't know if there's anything you wanted to.
Yeah, I'm sorry, I was waiting outside actually, so apologies for being late to the item. The only other thing I would add to that is actually that we, over the course of last year in particular, been doing a lot in terms of integrating sustainability into existing trust projects, and I think that's going to be really critical when it comes to looking at the kind of costs here, because actually, as long as almost we are putting sustainability at the core of everything that we do, then we've got a good chance of getting there. In particular, we've got some critical key priority projects across the trust, virtual consultations, community nursing review, which will have a positive sustainability impact in terms of those carbon reductions. But we've got to act now to get those positive impacts. So it's like integrating into existing work is just as critical as the additional costs which are coming up. And we've got a much better grasp of what those actually are now than we did 12 months ago, for example, which enables us to do much more in the way of planning for capital and all the rest of it. So, we know where we are much more clearly in that financial arena than 12 months ago, but still a big challenge up ahead.
Thank you. Sure.
But I was interested in our leadership regarding partnership working. We seem to be leading that as well, and how that is progressing, because clearly we've got sites where staff work together from different organisations. There's a lot of people travelling backwards and forwards to meetings, etc. I just wanted to have a feeling how that's progressing, and our other partners keen to get involved.
And we've highlighted in here some of the partnership working that we do. We work with a number of other trusts on this, and I think it's enabled us to share resources and reduce duplication in terms of delivering a sustainability programme. So, for example, one quite interesting example is actually we did a kind of a piece on EV charging at Sussex Partnership, and they went first on that, and then we at Sussex Community are taking on the learning from that here now. So we're much quicker at it because we've learned how to do it once. And there are other examples of tools that we've developed. The staff engagement campaign that we launched this year is running across Sussex. So there's interest, and I think because of the way that sustainability is developed in Sussex in particular, there's a really strong trust presence for sustainability. And in fact, the kind of NHS Sussex and the ICB piece is coming up behind that almost. It's getting there and it's doing well, but actually it's the trusts that are leading it, which I think is probably a good place for it to be. So a lot of opportunity, and we're looking with Mike at the moment of how to kind of formalise that opportunity, in particular with the NHS Sussex piece, more over the course of the coming months to sort of drive those changes and enable that system working more explicitly.
So I'm conscious of the time, I'm going to move on. I just wanted to make one other observation, which is there was an interesting piece here about the sustainability value of emissions avoidance. And given the enormous focus in terms of how do we deliver that more broadly across the system, it would be quite interesting to understand how we take value from that activity into the sustainability arena.
You just reminded me of a point I was going to make as well. So none of this is adjusted for the growth of the trust, and the trust has grown significantly over the last half a decade or so. And we might actually undertake even more activity, but that might be beneficial in terms of sustainability across Sussex. And it's a bit like some of the conversation around finance or other. We haven't yet got the sophistication of kind of those exchanges of, okay, we might increase our service provision, but actually it reduces the carbon footprint overall for Sussex. And that's not factored in. So the reductions you see are despite the growth in services. It's an interesting point to make.
Thank you. Thank you, Mike. Thank you, Susie, for the work you do in this space. And we have received the annual green plan. So let's move on. Item 11 is the integrated performance report for month 11. It's in our new format, which I continue to like. Mike, I will pass across to you.
Thank you. Yeah, a new refreshed format. We've got more timely data, so we're looking at the previous month's data, so to the end of February this time. So that hopefully gets and drives better conversations with the board. We've got the exceptions kind of up front, and we've combined those so you can rapidly see at a glance kind of where we are, where we have exceptions in our data. We've got a different form of exec summary, and actually we do, those still have all of the metrics at the back of the pack if people want to reference kind of the full suite of metrics. So I wasn't going to say any more, but I was going to do what we normally do and kind of move on. Unless anyone had any questions about the front of the pack, I was going to move on to the quality section. And done.
Thank you. Thanks, Mike. So I'll start with the exec summary. The successes actually we've already talked about. They're all within the improvement programme, so I wasn't going to spend too much time on those, but just to note the successes. And then just talk about the strategy and delivery section a little bit, very much focusing on AHP strategy delivery. There's some really good work happening around the AHP strategy, and including things like embedding core competencies with our AHPs, focusing on job planning, career development, promotion opportunities as well. We're looking at developing an AHP quality dashboard so we can be really clear about quality metrics and outcomes of for patients who are receiving AHP services as well. We've got an agenda item for the Quality Improvement Committee in May to look a little bit more in depth around the implementation of that AHP strategy. And then on the same theme around AHPs particularly, but not solely, we're working with the ICB around their rehabilitation work, a key element of which is around the personalised care agenda. And you'll see in future board reports, I think it's next month, is around our quality priorities and our quality account, where we're identifying personalised care as a key quality priority for the organisation, aligns with a lot of other things we've talked about today as well. And then emerging risks and issues. One was an emerging risk, but just to give some assurance, really, we've been working with the digital team to really strengthen the clinical digital governance arrangements, mainly through our CAG, our Clinical Assurance Group. And I think we've got to a good place really around that. And I feel far more confident that the arrangements that we have in place are really promoting good partnership working and sort of in a very timely partnership working between the quality and safety team and the clinical digital team as well. So that's been some good work there, I think, which will support our growing assurance around the digital agenda. The other emerging issue and risk is sort of an external one, really, which obviously impacts us, is around the Care Quality Commission. So I'm sure you'll be aware from previous reports and definitely through QIC we've discussed that the CQC have launched a new inspection framework. So the way that they inspect services is very different now to the days when they would pitch up for a week with lots of people and visit lots of our services and ask for an awful lot of information all within that week. So it's very much more sort of a continuous inspection and review of organisations and services. But we haven't been formally inspected, and our rating as a good organisation dates back to 2017 when we were last inspected. I think a planned inspection was cancelled with about 24 hours notice, wasn't it? Just before I started in the job, and it was just as the pandemic started as well. So we sort of slightly lost our opportunity then, and then the model of inspection has changed as well. So we have regular engagement meetings with the CQC, and I think it's sort of fair to say we are slightly frustrated that it's taken so long to implement their new model of inspection. They are now piloting it, but they are only piloting it, and they're piloting it in the south, which is great, but they're only piloting it with social care organisations. So limited sort of learning really for a lot of learning for them, but limited learning for us as an organisation. We've also been advised that they, at the moment, are not giving us any further detailed information around the guidance that sits behind the quality statement, so what the evidence might be to demonstrate that we have delivered against those quality statements, which you'll see on the front sheet of all of our board reports, or the characteristics of what an outstanding organisation needs to look like. So what we're doing, we've got a paper coming to Trustwide Governance Group next month, which will also come to the Quality Improvement Committee, is proposing a slightly more proactive approach where actually we are going to be proposing what we think the evidence is that will be required for a community organisation to deliver against those quality statements, and also what we think the outstanding characteristics would be, and then how we can kind of feed that evidence against those outstanding characteristics into the CQC to kind of support that continuous inspection type approach. So yeah, it's a little bit frustrating, but I think we have a plan.
So do we actually get an inspection timeframe window, anything like that?
So no. So the CQC, like I said, that it's a continual inspection model, so they can change the ratings of individual lines of inquiry, so safe, effective care and responsive well-led. They can change the ratings of any of the key areas, so adult services, end-of-life services, etc. They can do that based on the data that they have. They are highly unlikely to change the rating of a whole organisation without stepping foot into the organisation. So at some point, they will want to come to this organisation, but we are not considered a high-risk organisation by any stretch of the imagination. So I have no sense really of when that might be. I'm happy to take questions on that, or would you like me to just carry on to the exception reports?
Carry on, I think.
Carry on, yeah. 2 exception reports. These are both things we've seen before. We've had a flu outbreak in February in Crawley Hospital, 5 patients affected, no staff. We spoke previously around our reduction in the isolation periods for patients with COVID and HMPV. We are continuing that because it really is having an impact on flow. Our Deputy Director for Infection Prevention Control is talking to me about whether actually we make that our default position. In recognition, I think, of the comment that Siobhan said when she talked about her report around actually we don't really have winter busyness any longer, we have all year round busyness. So do we need to maintain that? Any change that we do around that, we will do in consultation with the system so that we're not out of step with our other providers within the system. So, and I'll let you know if we do decide to do that. The other exception reports around complaints, we had 2, very unusually, we had 2 that breached their target. There's some reasons there as to why that happened, but just to give you assurance that the complainants in both parties are kept informed of the timescale and why there's been any delay.
So in terms of those complaints, and that's the important piece, I think, from my perspective, which is we were communicating with them through this process, and actually they got an outcome at a time that they expected to get an outcome.
Yes.
Okay. Any other questions on quality? No? Thank you, Donna.
Thank you.
Let's just move on, Kate.
Thank you. I won't touch too much on the success here because Siobhan's covered it in her CEO update, but just to note the increase in activity through the launch of that web portal, which is really, really positive. I think I've updated before around the shift to looking at more heavily focused admission avoidance virtual ward. So that service is currently being remodelled with our acute partners through our newly appointed clinical leads, and we've broadened the Sussex programme to incorporate the virtual care programme. There were 2 separate programmes across Sussex, virtual care and virtual wards. I'd taken on the exec SRO role for Sussex for virtual wards, but we've now taken the virtual care programme into that as well. So we've got a virtual health programme we're looking at. That sort of end-to-end pathway in terms of remote monitoring at a sort of primary care level, stepping up into our UCR services and virtual wards, and only admitting to hospital if that's kind of the only place that a patient can be cared for, and then working back down that continuum. So that work is underway. There was a Sussex-wide discharge summit in February, and a general agreement across the system to pursue a discharge to recover. model to focus on patients really being assessed for care in their own home and getting as many patients to home or to their usual place of residence, which means a sort of shift in, for those of you that were kind of au fait with the pathways, pathway 0 to pathway 3 in terms of where patients are discharged to, a sort of shift in that across Sussex so that we start to see more patients discharged home and less patients discharged to a permanent care or residential placement. So there's work underway across the system to do some demand and capacity planning around if we see that shift, what we'll need to do in terms of the increased use of capacity of community services to enable that to happen, and what the associated shift of funding needs to be to support that. And then emerging risks and issues, the Diabetes Care for You service still has a risk on the risk register scoring of 16. There has been some improvement in terms of recruitment, and they are anticipating that they'll be able to reduce the scoring of that risk in mid-April. Should I just carry on, Mark?
Yes.
Okay, so in terms of exception reporting, average length of stay is still above target, but is reduced from the higher level in January. As I've kind of explained before, much of that is related to the number of patients who are no longer meeting the criteria to reside. The beds optimisation programme is still really focusing on reducing length of stay and particularly on reducing length of stay for those patients who meet the criteria to reside, because that is more within our gift. And we've just agreed to extend the beds optimisation programme for a longer time frame so that we can make sure that the changes we've made are properly embedded before we close that programme down. So we've extended that to 2024. You'll see that the levels of occupancy remain really high. So in February, 98% occupancy. The neurodevelopmental pathway I've reported on at previous board meetings. We do now have an external provider supporting the assessment of some of those children that are waiting. And we had a report recently to Exec Management Group, which assured us around the quality of those assessments being delivered. But the impact of that isn't yet being seen in the metrics, so we'll start to see that as we move through the next financial year. And then just in terms of 2-hour response, kind of continuing the theme of sort of increased activity, we had more than 3,300 referrals requiring a 2-hour response in the first 11 months of the year, and we met 3/4 of those within the target time. You'll see in that just the last kind of sentence in that box there, in December, SCFT's response rate was 2 percentage points under the national average and in the middle of providers across England. But the number of 2-hour referrals we had was the 10th highest amongst 113 providers nationally. So very high levels of activity, and we do meet the target of the 70% 2-hour response. As Siobhan just referenced earlier around national planning, it looks like their focus on that is going to shift moving forwards anyway. And then just to note on the community nursing slide, that the new community nursing improvement programme, which Donna is leading, is taking a very similar approach to the community beds optimisation programme in terms of its approach. And that's just kind of getting up and running in terms of establishing those work streams. Donna, if anyone has any questions on that, I might leave you to answer those. And then I've covered the operational risk slide.
Thank you, Kate. Just a question from me, if I may. NDP we talked about a lot. The thing I was just musing on was we talked about a target of getting back to mid-September levels. And I was struggling to see mathematically how that was going to happen, because I reckon that the gap between our current position and mid-September is about 600.
Yeah.
And we've commissioned 300.
Yeah.
At a time when demand continues to increase.
Yes, exactly that.
It will make a dent.
It will make a dent, and we've recognised that it will only be a dent because of the continuing referral rate. And I think I've talked before about the kind of local discussions and national discussions around the NDP pathway. There needs to be something fundamentally different in terms of the way the services are delivered to really make a significant impact on those children that are waiting.
On the 2-hour wait, are we going to hit a point where we're going to reach our maximum capacity with numbers continue to increase?
Yes, and I think that's linked to the sort of conversations that we are having around the kind of shift of capacity and how we increase community capacity. So absolutely, we will hit capacity. But if the discussions that we're having through the discharge programme sort of come to fruition, then we should be able to, we should have agreement across Sussex that we expand to meet demand.
With extra funding?
With extra funding, yes.
Thank you. But I smile when I hear the discharge recovery.
I saw you smiling.
How many times we talked about that? And the main thing that usually scuppers it is people's ability to take risk or risk assessment. How are we actually dealing with that? Because it's fine to put pathway in place and even additional resources, but if actually clinicians within the acute trust are not prepared to make that decision, actually it won't work.
Yeah, I mean, I'll answer it, but I don't know whether Karen and Donna might want to come in on this one as well. I mean, we had exactly that discussion at the Discharge Summit, and a recognition of exactly that often community clinicians will take a higher level of risk than acute clinicians, and a real, I think, appetite for everybody to be working much more closely together to address that. And I know the acutes are doing some work, particularly with their therapists, and have agreed that we will be part of those conversations. So I think that will start to make the difference where we've got clinicians working much more closely together. We've also talked about things, I mean, Leslie, you'll have heard all of this before, but if we could get some more rotational posts so that people are rotating out of the acute and into the community and get a much better understanding of the levels of risk we can hold in the community, hopefully we'll start to shift that position. We've also talked a lot about putting a much more of a pool model into the acute so that it will be community staff that are deciding when a patient is safe for discharge.
And we'll have the ability to make that decision now.
Hopefully.
Okay.
I did have one question that, and I guess it is for you, Donna, then around the community nursing metric. I just wanted to check from a measurement perspective, because this talks about face-to-face contacts per 10,000 of the population. So it's people rather than visits that this is measuring. So if I go and see, if I'm a community nurse and I see the same patient 20 times, it counts as one against the population? Yeah. Because I can't work out whether this is a movement in...
But this is contacts, isn't it? So if you see the same patient 20 times, it's 20 contacts.
Right, okay. So what this implies is a declining volume of contacts per person over time. Is that what I'm reading correctly?
Yes, yes. Okay. But look at this in context with the paper we've previously had around improvement programme, where you can see we've identified some metrics around community nursing. Because I think this is, it's a metric. It's got flaws, shall I say?
Yeah, I was trying to triangulate between the number of days that someone stays on the caseload, which implies you may see someone for more than others might do, versus whether that's creating capacity or not. So in my mind, I haven't quite squared this set of metrics with the intent around the caseload duration management.
Yeah, it is. I suspect what it is that patients are staying on the caseload for longer, but because they are receiving less visits. So if we can be more focused around the reason why patients are receiving nursing care in the community and what the outcome needs to be for that patient, and identify when they've achieved that outcome, and therefore we can discharge them from a caseload, then it's a more focused piece of work. Patients won't stay on the caseload for longer, and the visits that they have will be very targeted and focused on what the purpose is for their visits.
I'll see how it moves as we go through.
Yeah.
Karen.
So a slow reply, Leslie, to yours, percolating. I think the other element of this that will play through is our focus on personalised care and personalised care and support planning. And within the quality account priority, there's a focus in quarter 4 to be looking to increase the piloting and then embedding of the use of a digitalised personalised care and support planning tool, which I'm really excited about. So embedded within that is also an outcome metric, GAS, so goal attainment scoring. So actually measuring whether we're meeting that person's individual goals. And within those individual goals, for a lot of people, it will be that wanting to be at home.
Yes.
And so actually the work that we're doing in the proactive space with those personalised care and support planning will play through in terms of, I hope, those conversations if that person does end up in an acute hospital to meet their wishes to come home. So that supports the clinician with taking that measured risk because it's what the patient's wishes are. So I think that's a fundamental part of what we're working on.
That sounds like a game changer. So
yeah.
thank you. Yeah, it's very positive.
Yeah, I'm very excited about it. It's being piloted in our post-COVID assessment service at the moment. So
good. We shouldn't gloss over the risk. We know that podiatry has been an area of focus for some time and continues to be. There isn't a quick fix, but it's helpful to understand that action has been taken in that aspect as well. Thank you, Kate. Caroline.
Thank you. Just a couple of points to note, really. I want to talk about the staff survey because we've done that at length today, although I will talk about the staff survey in relation to PDRs and particularly the questions that the board asks quite rightly around the quality of our PDRs. And just to say that we are improving year on year on the 3 questions relating to the quality of PDR, and we are the best result for the question. It left me feeling valued by the organisation. So we are talking class on 1 question. I understand it's not a whole people promise, but
don't look at me.
Here we go. It's getting there. Well, yes. And I think a couple of other things to note, really. I think looking at the next iteration of the development of our medium workforce plan, which I know is being discussed both at executive management group, people committee, and there will be a session with the board later this year. Sickness and targeting sickness is going to have to be one of our priorities in 24-25 because the unavailability of people on a day-to-day basis is greatly impacted by our sickness rate. So we have to do better on that. We have to think differently, and I think that will be my focus for the next few weeks to work out what that looks like. In terms of the not yet received formally planning guidance headlines around workforce, just to give some assurance that we are doing all the things that we will be expecting to focus on in 24-25, whether that's our rostering solution for the whole organisation, which, as you know, is a corporate objective, whether that's supporting staff. We already have a menopause policy, for example, and we've already adopted the national baby loss policy. Those are some of the things that have been highlighted as supportive for staff. We talked about the 5 high impact actions earlier in the agenda. We've talked around our people promise focus and the work that Denise has been doing in that. And as you may know, I'm the ICB lead for growing the occupational health service in Sussex and working differently. So having had a very quick look at the headlines, they've all been addressed. The final ones around sexual violence, and again, we talked about that earlier. So although I haven't done the in-depth analysis yet of what's needed, I think the headlines, as I've seen them, have been covered just through our agenda today. Happy to take questions.
Thank you, Caroline. Just an observation, actually. I mean, workforce metrics are a strong performance across the board, and they clearly do. And I was particularly pleased to read about the progress on the strategic workforce plan, because we've had that sort of disconnect, haven't we, that says all the short-term stuff looks really great, but we're continually worried about that longer-term play. And I'm really pleased, because that, for me, I think is the piece of the jigsaw that then starts to say, as we've talked before, actually our workforce risk reduces because we're in a great place now, and we can see that direction travel and broader path. So I think that's really positive.
We had a good discussion at Exec Management Group yesterday. I think we're calling it a medium-term workforce plan to try to somehow ground it in delivery and not have it as a sort of ethereal strategic view. But the sickness point we had a good discussion about yesterday, because now that we've done that work, we can numerically see how many people on every day of every week of every month are absent from work due to short-term sickness, and therefore, you know, the impact to others when we've already talked about increased demand and increased waiting lists. So we're going to use the initial phases of that medium-term workforce plan to create a sort of comms and engagement activity over the next month to get that information out there, because we want people to understand that, of course, we are an organisation that takes care of everybody's well-being, and also we have to collectively work together to reduce sickness, primarily because we are an outlier, and we have consistently been an outlier in terms of benchmarks and national averages. So it's the one area that we recognise through all the statistics we're an outlier for, and we need to do something differently. But that medium-term workforce plan that Ed and Caroline have been leading on has helped us to get more granularity in that space. So it's just one example of the practical application of that work around medium-term that will help us.
And I guess the rostering activity also supports that broader focus around sickness impacts. And
absolutely, yeah.
any other questions for Caroline? Thank you. Do you want to say any more about the staff survey?
No, I think there's a risk I might just focus on what we're going to do better next year. So I think I'm just going to leave it there.
Well, move on
Quick when you're ahead on that.
Let's move to finance.
Thank you. We're just looking at our key successes. Although we are off plan at month 11, we've been continually kind of delivering surpluses now and kind of coming back towards break even over the last few months. So we are on track to deliver a break even financial position, and to know that included going a bit further than break even and an income reduction, which was then redistributed back to the system to help the overall system position. So in a really challenging circumstance, a really good result for Sussex community, I think. So and other metrics are looking good as well. The capital is an exception because it's a higher than sort of ever month really of capital spend, but that's also because we're moving back towards catching up and spending our capital plan as expected. So we would expect another high month in month 12 when that comes through. In terms of what's been going on across the system, because the financial situation is very enmeshed within the Sussex system. That's the way the financial architecture works. So we have been developing financial plans. We've put in a draft financial plan for next year that is break even, but that's in the context of a Sussex plan that isn't break even, that does have deficits across a number of organisations. And there's a lot of challenge in there. So looking forward over the next few years, we're trying to manage our financial risk, but there are a number of risks that play into next year. There'll be risk around the pay award again and whether it's accepted, and therefore whether in the end funding that we get matches kind of the expectations of staff in the pay award. There's the operational risk if there's continued industrial action. There'll be the risk of trying to achieve such a high efficiency rate to deliver a break-even plan. We were looking yesterday, it's just under 15 million of efficiencies needed to be delivered. We were looking at that at Resources Committee, and there will be risk of inflation still. So inflation is dropping, that's great, but that's already been reflected in the financial allocations. So kind of nationally, they've taken that opportunity away from us, and if our contracts and our inflation experience varies to that national average, we will get exposed to inflationary impacts, and we're already aware of some of that risk. So quite a lot of risk going into next year, but a break-even plan, and we'll continue to manage those risks sort of collectively at EMG and through Resources Committee.
Thank you, Mike. We're close to the year end. Any questions to Mike on finances? Anything else anyone wants to pick up on the IPR more generally? We've got the detailed dashboards coming through. Sure.
I was just reflecting on the conversation and the new format, and a couple of reflections, which was precipitated, I think, by your question about NDP, Mark. So first of all, on the performance dashboards that we look at, I think we probably need to do better at creating targets, because if we're going to use statistical process charts, the only way we know whether we are doing well or not over time is to be able to track targets. So when I look at the number on, say, the operational performance dashboard on 148, we've got 6 areas with target TPC, and a lot of them are around weighting, which is why I was kind of, my thought process followed your question. So in the exception report for NDP, we only focus on the new contract for the 300, which you rightly pick up as not being able to provide assurance or mitigation to the risk of the 2028 we've got waiting. So I think if we changed our thinking about having some kind of targets, then it flags more accurately in dashboards, and then I think we look at it more generically. So I'm trying to link the fact that our narrative in some areas is not perhaps looking at the totality of the metric. And I think NDP, there's not many, but NDP is a good example of that based on the question you asked. So the reason I say that is I haven't seen the planning guidance, but the headline is community weights need to reduce. So we are going to have targets to demonstrate trends over time that we are reducing. So I think in the construct and the format of it, probably Mike and Kate in particular, I think for quality, we always say we don't want a target around an ever event. We don't want a target around things that shouldn't happen. So I understand that performance dashboard more, but the more I look at how we've constructed the new version, we're not able necessarily to look at the part, the hitting the target over time or failing the target over time because we haven't got targets in some key areas. So that was number one. And number two, just briefly, similarly on workforce, the team will know I had quite a lengthy discussion with the team and myself yesterday about turnover. And I think turnover is another great example when you look at the workforce dashboard. So the SPC emblems are the grey common cause, and then the assurance is we can't give assurance because it's variable. And what we discussed in the medium-term workforce plan paper yesterday at EMG was a critical factor on delivering our medium-term ambitions is reducing turnover and keeping turnover as low as possible. My question to the team yesterday was, when have we talked about turnover at board? And then when I look at this dashboard, I think it's not flagging to us because it's saying we've got a 0.72 monthly target. Actual and against a target of 1.43, but it's not telling us whether it's favourable, adverse, whether it's variation, whether it's assurance. So I guess in summary, I think this is a good iteration, and the teams and the exec team and teams have worked really well to get a better IPR. I think with some fine tuning, it can drive us to some really important questions, both aligned to what the operational plan nationally is going to tell us about community weights and about our workforce in the context of the medium-term workforce plan. So that sort of emerged through the conversations, because I've obviously read this a couple of times, but I was trying to think, does this version drive the right conversation, drive a better conversation? And with a couple of tweaks, I think we can get more specific at board.
And I think that's really important. I think the fact that we've got more current data is a really positive thing. I was going to ask you a question about, does it work for you, the exec? But I think what you've said is this is a positive direction of travel, but we, particularly in the light of new guidance and focus, just need to just make sure it is facilitating the right conversations. So that's really good. Thank you. Okay, and I did notice that Mike, because he produces this, puts finance as green, so there's a lot more green on his page. I'll just leave that one out. Right, let us move to the committee chairs reports. Mandy, if you're able to speak, is there anything you want to say?
I can just about. Yeah, I was going to say, I think I can probably save a bit of time here because I think we've covered most of the areas. I mean, it's been there's been some good progress across the board. There's no point in diving again into all of the stuff that came out of the staff survey. I think just lots of assurance, I think, from the people committee side, that we look at the measures kind of one level below the ones that come to board, and it's been very positive kind of across the piece. And there's just been big improvement in time to recruit, in retention after a year, all those kind of things. We had a really interesting session around flexible working, and I think it's one of the areas that I think is bridging the gap between the kind of here and the now, and thinking about how do we continue to retain and attract people going forward. And it's just nice to see some kind of innovative thinking around how can we do, we get good feedback on our flexible working, but how can we go further to make ourselves kind of ongoing an employer of choice. We also saw the violence prevention reduction report, which was kind of, I found a bit shocking personally, but I think yeah, I mean, one of those kind of areas that we really need to kind of keep an eye on, and I think there's some sort of headlines in the chair's report about that, but just more work to do in terms, and some good things happening in terms of trying to empower staff more so that they feel like, you know, what, some more clarity about what they can and can't say and do in some of those really difficult situations. So I was going to say, overall from the People Committee, I don't have much to say unless anyone has any questions.
Thank you, Randy. As you say, I think we've covered a lot of those items already, and picked those up. So it's just helpful to have the clarity that actually the discussion is happening at committee before we bring that to high level to board. I won't ask you to say anything more, and hope that you're better soon. Okay, next item on the agenda is Resources Committee. So I put my Resources Committee chair's hat on. You get two for the price of one with me. So you've got March and February. You know, we're at the time of year when the key area of focus is around money, the glide path into the end of the year, and the budgeting for next year, both of which Mike has articulated very clearly in relation to what, you know, where we will land and what we are contributing to the system more broadly. So I'm not going to highlight anything there. I think the one thing I just call out for the board is actually we've seen some really interesting use of data and insights. And you know, this month around the service level reporting and patient level costings, a lot of work has gone on to produce information, and the key question was, how do we turn that data into insights, into something that's used by the services? And Kate, I've forgotten the lady's name already.
Sarah Bird.
Sarah joined us in the meeting Resources Committee and was talking about how she's starting to take that information into her world and just test and challenge around the way in which the team operates. So for me, that's really powerful. And we've seen other data points, some of which actually need more work to make the data good, because we're not as comfortable as we want to be with our ERIC data, for example, and stuff like that. But I think the broader recognition of the importance of getting the data right and then using it for insights, I think is coming to the fore more in the Resources Committee. So, and for me, the key thing is the insights that are then usable across the organisation. So I won't say anything more there because I want to get back on track. But any questions, happy to take those. No? Okay. Let us move on to item 14. We have a number of quality reports, each of which have 10 minutes maximum. So we'll have a focused conversation here. So first thing, FTSE Guardian report, Donna, to you.
Thank you, and apologies for Mary Bell, our FTSE Guardian, who's unable to join us today. Two elements to this report. So this is the Q1 and Q2 report. Again, apologies, this is late. I think we had a few kind of gaps in our sort of board governance arrangements, which is why it's been delayed. You've also got an appendix, which is a summary of the National Guardian's Office self-reflection and planning tool. The other thing to note when we're looking at this report is that we are working with the performance team to think about how we can present our FTSE data in a slightly different way. We've had this data for quite a while now, and I think we need to start looking at it rather than in isolation in a quarter, but look at it over a period of time so we can see what the themes and trends are. So I'm hoping that the next report that you look at will look very different. But some of the key highlights, that the figures are very much comparable to monthly averages of sort of 15 to 20 cases, and most concerns are managed through close working between the Guardian and the local management for resolution and then shared learning. We do send out an anonymous survey to staff who raise concerns when their case is closed. And out of the 19 cases from Q1 and Q2 that are closed, we've had responses from 15, and they've all reported that they would speak up again. So I think that's really positive feedback. 4 people haven't responded, so it's a neutral rather than a we wouldn't do this again, I think, response. And the other thing just to note is around the focus on detriment, and you can see in the appendix in the self-reflection tool we've identified that as further learning for over the next 12 months as well. It's really challenging to identify detriment in a way that meets both the definition of detriment, but also meets an individual person's perception of detriment, and to understand how we can minimise that and do the right thing for the person or the people involved. I think it's really important that we kind of get to that place. So those are the main points from the report, and then the self-reflection tool, which we've completed. This is the NHS England and the National Guardian's Office self-reflection tool. We complete this every 2 years. Some of you will remember being part of a board self-assessment back in, I think it was February 2022, I think, when we did it last. So the full report has been to the Quality Improvement Committee. This is a slightly different report. It's very much a reflection rather than a self-assessment, and it's very much focused on identifying areas for improvement. And the areas for improvement that we identified are at the very end of the report. But some of the key things are, as I've said, a focus on detriment and using an evidence-based tool that another guardian in the South has developed to tackle inequality and disadvantage. Continue to recognise the impact of the ambassador role. Also to consider using maybe a sort of a model that's a bit similar to the after action review, which we use when we're looking at patient safety incidents, when we might want to debrief and review how we've managed some FTSE, a small number, but some FTSE issues when there have been sort of multiple strands to that issue. We've had multiple people involved and they've become quite complex. So just to maybe use that model to understand whether we've done that in the best way, really. And then, as I said, a review of reporting so we can look at trends and analysis over time. So that felt like a bit of a whistle-stop tour through.
Whistle-stop tour is fine, Donna, thank you.
I got that impression.
Can I just check, how do we triangulate, or do we triangulate what the FTSE Guardian is seeing from their data perspective versus what we see, for example, through the staff survey? I can't remember what the particular questions are, but I know there are questions about people's willingness to speak up and that sort of thing.
Yes, we do. I mean, we triangulate with both the quality and safety team and with HR and that workforce data, not just the staff survey, but we triangulate with other workforce data that we have as well. So Mary engages very regularly with Caroline to look at that information, and we feed that into our overall approach to data and understanding which teams are the teams where we have higher concerns around those teams, which is sort of held in HR.
So are we seeing consistency, or are we seeing anomalies in the different areas?
Generally consistency.
Yeah, there's a lot of consistencies, and I think our reflections, I think both Donna and I are around the reasons for going to the FTSE Guardian are very similar to people going to for an HR process, for example. So often it will be about breakdown in relationships, in civility, and there are other issues, but there's a lot of focus around people getting on or not getting on with people. So I think there are not always an HR process involved with that, but sometimes it will lead to an HR process, or it will be resolved outside of an HR process. One of the things that we are looking at from April is, and Mary will be involved in that with other people, is looking at setting up mediation clinics so that people who go to either HR or the FTSE Guardian or other sources to talk about their experiences of working with others and not getting on can be taken through that route and as an alternative. I think that will help with what Donna is talking about, especially the detriment bit, because often it's not detriment, as Donna said, with regards to the definition by law, but it is a detriment because people have, don't get on anymore and feel that therefore they're not going to be treated in the way they expect to be treated or want to be treated. And if you can solve those issues early on, then we think that we'll be able to reduce those people feeling that actually they've had a detrimental impact of raising a concern, often perceived as opposed to something we would be able to define in the legal capacity. That doesn't mean it's not right for them, it is their experience.
One of the things we identified, Mark, because obviously FTSE comes to QRC quite frequently, was around leadership and leadership behaviours. And we were really pleased to hear that through HR and Denise, there is now a focus on leadership training across the whole organisation, which I think will impact on quite a lot of the areas that have come up in QIC over the past months.
I think Donna's written that the intent to move to themes and trends, I think, is a really powerful one, because you read it and it feels like there's consistency in what we see, but it's useful to understand that. And I think the other thing is also scale, because we're an organisation of 5,500 people, and therefore it's important for us to know whether it's 1 or 100 in terms of the concerns. But it's an area I know that has enormous focus and engagement at NED level with Leslie and through QIC and through the broader work of the Guardian. So vitally important, and I think what you're talking about in terms of enhancing it, I think is really powerful. Thank you very much. We will move on to the patient safety incident report. Karen.
Thank you. So this report is for Q3 and 4 assurance, and thank you to Debbie Fron, who's worked on this as a very new approach to this report. So this has been presented in 2 parts previously to board, and only part B has come to board before, that has been focused on SIs. We've now transitioned from the 1st of January to the Patient Safety Incident Response Framework, PSIRF, and this new summary report of key patient safety information includes reviews of our patient safety priorities according to our patient safety profile and our incident response plan. Our priority areas are pressure ulcers, slips, trips and falls, medication and deteriorating patient events. And these areas have been thoroughly reviewed through TWIG and through QIC. PSIRF advocates a different approach. It's data-driven to determine our incident profile with proportionate responses to incidents and patient safety priorities. We now use a range of different learning responses, so such as hot debrief, after action reviews, thematic reviews, etc., which reflect human factors. The next quarterly report that I'll be bringing will include more information about these for board. The focus previously was on level of harm when deciding the learning response. It now emphasises level of risk and potential for learning. The full patient safety incident investigation will still be undertaken in the event of a permanent or fatal harm to a patient, and the duty of candor still remains applicable to all incidents resulting in significant harm. So since we put this into place, we traditionally have a high level of patient safety reporting. We did see this dip in December when we transitioned over to in-phase, which is our new reporting system. But this is beginning to show a really good recovery. In terms of the different priority areas, we've seen that the learning from these across these areas are already aligned with current improvement work identified. One area to flag is we're scoping out an improvement work at present around a theme with medication, which is administration of insulin in people's homes. And that will include input from our patient safety partner, who's an expert through experience. In terms of other more significant incidents, we do have one relating to a patient with learning disabilities that triggered commissioning of an in-depth investigation. This did not meet the previous SI criteria for declaration then. We have 2 clinical negligence claims and 5 inquest referrals for board to note, and also wanted to flag that we're now able to report examples of good care through PSIRF, and we plan to work with our teams to support this. Our next quarterly report will include more information about learning outcomes, emerging themes, and updates on improvement work. Happy to take any questions.
Thank you, Karen. Leslie, I know it's something that is picked up very regularly.
It is, and can I just say what a fundamental change this is, because I think when you just read it in a report like this, it doesn't actually demonstrate the huge amount of work and the transition in mindset that people have gone through and the team that have led it. So I just want to thank you, because I think this will give us as a board a much greater insight into what the key issues, clinical issues are for us, and more importantly, ongoing the learning that we're going to and the change that's going to happen because of it. So this is a really good start in terms of report, but it means everyone's got to get their head around a completely different language, of course.
Well, it's a huge thank you to the team. Actually, they've led a fantastic piece of work in terms of maintaining that real focus on patient safety and learning throughout this as they transition.
And I'm conscious that the board has been on that journey around understanding the new language. We talked about a new system being in place. Are we comfortable now, Karen, that we're back to a position of, let's say, normality, if such a word can be used in this?
I think so, yes. I think this is the start in terms of how we're presenting it to board. I think that real focus on learning is going to start to flourish as we go through our reporting.
And I think the learning outcomes piece is really interesting. I'm conscious we have data around claims and inquests. Yeah. And it would just be really interesting to see whether there are observations or particular aspects that we need to be thinking about from that, as well as our broader activity as well.
Yeah, we had a discussion this morning on exactly the same thing. So yeah, starting to reflect on that too.
Any other questions, comments, or observations? No? Okay. We'll move us on to the mortality review report, which is also with you, Karen.
Thank you. So this is also for Q3 and for assurance. So it's a summary of our intermediate care unit mortality reviews using structured judgment forms. And the aim of this is to identify if we could have improved the quality of care, identifying trends, or if any of our ICUs had a higher than expected mortality rate, and take any necessary actions to address this. We've also had the medical examiner process go live, and since the introduction of this, our review supports wider learning and dissemination of best practice around the ICB area. So for Q3, we had 3 reported deaths in our ICUs. All the patients had escalation plans written up. There were no suboptimal care provision, and there was no avoidable deaths. In terms of highlighting good care, that focused around communication, teams, documentation, keeping families and carers involved in discussions regarding treatment and the care given by our teams. There were a couple of learning points that came out of discussions during this review. One focused around the fact that patient transfer and clinical information was not always available to clinicians from the acute trust, and some concerns in one case about the extent to which a patient and families have been informed about their diagnosis and their management plan by the acute trust. So we're picking that up through actions with the Community Hospital Transformation Project Board. Thank you. Happy to take any questions.
And where we talk about the good things, and one of them being keeping families and carers involved, is that our view, or is that feedback based from the families and carers?
I'm going to have to take that back. Have a look at that as to where that's come from.
Because it's so important, isn't it? In situations such as this, the way in which we communicate, and there can be a difference between what we think we've done versus actually what's being received. So,
one piece of assurance I can give you, Mark, we had a patient story at last QIC, and the patient had died, but the family were very complimentary about how involved they'd been kept during that process and the engagement. So it wasn't directly from a complaint, but it was through a different route, as it were. So just as an example.
Yeah, good challenge. We'll take that back.
Any other questions, comments? No, then I will move us on. So the QIC Chairs report, Leslie.
Yeah, and I apologise, it was long this time, but we covered an awful lot in the last meeting.
I look at the length of your agenda.
Yeah, quite. Just to, I mean, obviously we've talked about quite a lot in the previous agenda items, but there's just a couple of things I want to bring to the board's attention. We've talked about more generally about how we triangulate and use a range of metrics in various agenda items. But it's a new term that came through quite a few of the agenda items called blending of data approach. And because of that, and taking data from a variety of different sources, I think QIC are now able to give assurance about the safe care that's provided to the organisation, because we've seen some of that blended data that shows actually, although some metrics may not be quite at optimal level, overall the impact is fine and the care that's delivered is safe. The other area where we really saw this in action was around the quality account priorities, which are under development for next year. And clearly the quality account will come to the board in due course. But I've listed there what our proposed priorities are. And actually it's quite timely because you can see over the course of the agenda items that we've had where some of these have come from. And again, it's back to using that blended data approach. One of the things we did pick up though was about how we carry on priorities, or the work continues on priorities from the previous year. That's something we've asked Karen and Don to go and think about. Do we just stop them, or how do we, if the work hasn't continued, how are we assured that actually the work will carry on even if they've not got the focus of quality accounting coming to QIC? The other area I think you should be aware of is around the Safer Staffing 6-monthly update. A lot of work has gone on around benchmarking that, and there was a proposal to increase the number of registered nurses and at the expense of the registered nurse associate posts, but that needed to go back to exec team for further discussion and looking at if there, although we were assured it was cost neutral, clearly that needs to be tested by the exec team. So happy to pick up anything else, but I think a lot of it has been covered.
The point you made about priorities from previous years, I thought was a really important one, not just for QIC, but actually for all of our committees and more broadly across the exec, because there's always a risk, that annual focus and the reset over Easter, and we're into a new financial year and all that sort of stuff, just making sure those things that we said were important and we wanted to focus on, we actually make sure that if we had to take a bit longer on it or haven't quite got to where we wanted to, we could make sure we do that. So probably a prompt for all the committee chairs just to be thoughtful about that as we come into our new cycle of business.
Leslie, I was just wondering your views on hearing the patient voice. So I know in this particular committee, you referenced that it was around an incident, a patient safety and learning incident that we had the patient voice. But if I think about the CQC asking me an exam question a long time ago now, how do you hear the patient voice in the service improvements you make? I just wonder whether you think we have made sufficient progress and got the right focus as QIC chair in that space, or whether that is somewhere that we also need to focus this year.
I think there's somewhere we need to focus. I mean, I've said it before. I mean, what I was encouraged by is the new way the patient experience report came to QIC gave reference to the work of the patient experience group, and they now are looking at improvement as well. So that feels a bit more focused, but we need that reporting route through, because at QIC, what we have only seen up to now is really the formal side of complaints, PALs and the rest. And that's not truly what a patient voice is all about, which is why we introduced that further item. But I think, and clearly at board we hear a patient's story, but it's not quite the same. I don't think we're really hearing the patient voice coming through. We are in some way through the beginning of the improvement work and our patient safety partners, but I think it does need to be strengthened and developed further.
If I could just add to that, we also saw the beginnings of a plan to develop the next patient engagement and experience strategy. And we were really clear at QIC that the board needed to have involvement in that. And I think improvement needs to be an absolute fundamental part of that. So how do we hear the patient voice through our improvement programme? And how do we use some of the skills of the people who support this organisation to help us in our improvement programme as well. So that will be a focus, that needs to be happen by the end of this calendar year. So we've got time to do that. And
the challenge is always how do you hear the voices of people that are less willing or able to speak up, as opposed to those who are more comfortable doing that, because that's often where some of the really interesting movements.
Yeah.
I think it's how we use the patient safety partners as well. We've got 4 of them now. Some of them are quite keen. Clearly, some of them have got single focus issues, but we need to target those and actually help them to help us in many ways.
I wonder where the best sort of governance route for this, because I can recall having quite a good library of evidence of this at a time where we had to be more commercially active in bidding for services, and many number of years ago. And I can remember identifying particular patient engagement groups for particular services who could articulate how we'd improved Sussex Rehab Centre through direct and regular feedback with a patient user group who were driving improvement with the service managers. So that's one angle of what service user groups do we have where people are coming together with our teams and saying my lived experience of this service is X and Y, and it would be better if Z was added. And so I can't quite point to whether that comes together with the patient safety partners, with the voice of the patient. So because the answer we'll need to have when we're inspected is systematically, how does this board assure itself that improvements are made based on feedback from patients, not sporadically, but systematically? And I'm sure it exists, but I'm just not sure we have joined it all together yet. So I don't know, Zoe, if you've got any ideas about, from a governance perspective, where should we try to bring that together? Should we, as a board, ask QIC to do that? Should, as a board, we get involved in that through, as Donna said, the development of the new patient engagement experience strategy? Or do we need some time to think?
I think we probably need some time to think, but I think probably a mixture of both.
Okay.
It feels broader than QIC.
Yeah.
It is, yeah.
And I think the patient engagement strategy would be really interesting, and particularly how we start to embed that into it's not just about going out and engaging, it's about